Welcome to the deep dive. Today, we're jumping straight into something really fundamental and honestly pretty brilliant that your body does. Acute inflammation.
Yeah, it's a core process.
Totally. And this isn't just about, memorizing lists of facts. We want to help you really understand your body's incredibly smart protective strategy. Build that solid foundation for your medical journey.
Exactly.
So imagine this. You slice your finger. Ouch. What happens almost instantly gets red, starts to swell up, feels hot, definitely painful, maybe a bit hard to bend, right?
Classic signs.
On the surface, they seem, well, bad, like your body's just complaining lightly. But what if these problems are actually a deliberate, highly orchestrated defense plan?
That's the key insight.
We're going to uncover why these things happen and how they're absolutely essential for kicking off the healing process. So let's really unpack this crucial defense mechanism.
Right. And that's our mission today. We're going to take all the complexity of acute inflammation and, distill it down into something clear, something memorable. We want you to get not just what happens, but why it happens. We'll use some helpful anchors, metaphors, specific clinical examples from our sources too.
Perfect.
The goal is to give you those foundational insights you'll definitely lean on throughout your whole medical career.
Okay, let's start right at the beginning then, the basics. When we say acute inflammation, what are we actually talking about?
So basically, it's your body's immediate, very rapid protective response. It happens in living tissue that has a blood supply anytime there's an injury.
Living vascularized tissue. Got it.
Yeah. Think of it as your body's built-in short-term first responder team, its main job. Limit the damage and start the repair process right away.
And the acute part is important, you mentioned.
Oh, absolutely crucial. You've got to distinguish it from chronic inflammation. Acute inflammation, it develops fast hours to days, and usually it's done within a few days, maybe a week or two.
Okay.
We came up with a little anchor for you. ACUTE always clears up, typically early.
Huh, I like that. ACUTE always clears up, typically early. So chronic is the long-term stuff.
Exactly. That hangs around for months, even years, because the trigger, whatever it is, just won't go away. But that's a whole other deep dive for another time.
Right. So focusing on acute, what actually causes it? I think most people jump straight to infection.
And they're not wrong. Infections are a huge trigger. Bacteria, viruses, fungi, they all have these unique molecular patterns, PMPs we call them.
Pathogen-associated molecular patterns.
Yeah, you have endotoxin from certain bacteria, big trigger. But, and this is important, it's definitely not always infection.
Okay, so what else?
Well, there's a whole range of non-infectious causes. Things that trigger what we call DAMPs, danger-associated molecular patterns. These are basically alarm signals from your own damaged cells.
Ah, so internal danger signals. Like what?
Think allergens, toxic chemicals, irritants maybe like nickel in jewelry, foreign bodies. A splinter is a classic example.
Okay.
Also burns, physical trauma, radiation, even just tissue necrosis, cell death itself.
So the body basically sees all these different things, bacteria, a splinter, a burn, as danger, and kicks off a similar response.
Pretty much, yeah. The initial reaction is remarkably consistent. And that consistency is why doctors, even way back in ancient times, could spot the key signs, the 5 cardinal signs of acute inflammation.
These are the big ones to know clinically.
Absolutely. They are your anchors. You'll hear the Latin terms rub, tumor, calor, dolor, functiolasa, but we have a handy mnemonic for you, preach.
Preach. Okay, let's break it down. P.
P is for pain, dolor. And it's not just annoying, it's nerve endings being stimulated by chemicals telling you, hey, protect this area, don't use it.
R is redness.
Rubor comes from vasodilation, blood vessels, widening, rushing blood to the site.
Right.
I is immobility, or you could say loss of function, functiolasa. That happens partly because of the pain and swelling, and partly because your body just naturally wants to keep the injured parts still to help it heal.
Makes sense.
S is swelling, tumor. That's the actual accumulation of fluid and immune cells building up in the tissue. You can see it, feel it.
And H?
H is heat, calor. Also, from that increased blood flow, makes the area feel warm, especially on the skin.
Preach pain, redness, immobility, loss of function, swelling, heat. Got it.
So let's revisit that question from the start. Why? Why these seemingly bad symptoms, the pain, the swelling, heat, redness, inability to move properly, why are they actually protective? Keep that in mind. We're going to connect the dots as we go.
Okay, we'll do. And you really do see pre-sheet everywhere, like cellulitis, right? That skin infection, maybe from an ingrown toenail gone bad. See the redness, the swelling, it's super painful, feels hot.
Big example.
Or even just a simple blister after wearing new shoes. That bubble is the swelling, right? Acute inflammation right there.
Exactly. Your body's putting up the big visible sign saying damage here, defense underway.
All right, so we know what it is, what it looks like. But how does the body pull this off? It sounds complex, but you said it's controlled. Orchestrated, even.
It is. It's not chaos. It's run by a whole host of chemical mediators. Think of them as tiny messengers, signaling molecules, each with a specific job, dictating the whole inflammatory response.
Yeah.
And they're tightly controlled. They don't last long. They have specific inhibitors. They can come from inside the body, endogenous sources like plasma proteins or white blood cells, or sometimes exogenous like those bacterial toxins we mentioned.
So who are the main players in this chemical orchestra?
Okay, let's break down the key groups. First, you've got the vasoactive amines. These are the quick responders, top of the list. Histamine.
Histamine. Hear about that a lot with allergies.
Yep. It's pre-made and stored in mast cells, basophils, platelets, ready to go instantly when injury hits. Its main jobs. Rapid vasodilation, widening those blood vessels and increasing venular permeability. It makes the cells lining the small veins contract, opening gaps, letting fluid leak out. The floodgates effect. And yes, it contributes to pain.
So quick vasodilation, permeability, pain. We can use your anchor. Histamine, hydrostatic high harm.
Perfect. Serotonin, mostly from platelets, does similar things, but histamine's the bigger player here early on.
So histamine rings the first alarm, widens the roads, opens the gates. What comes next? Are there other chemicals involved in those initial vascular changes?
Oh, yeah. Next up are the vasoactive peptides. I call them the pain and permeability duo. The main one here is bradykinin.
Bradykinin. Okay.
It's formed from a precursor that's already floating around in your plasma. Bradykinin is potent stuff. It also ramps up vascular permeability, adds to the vasodilation, and it's a major cause of that intense, sometimes burning pain.
Burning pain. So bradykinin, burning blood broadening.
You got it. Helps to remember its key roles.
Okay, so histamine and bradykinin handle a lot of the vessel changes and pain signals early on. What else?
Then we have the arachidonic acid metabolites. Think of these as the local effectors made right there at the site from cell membrane lipids. Two big families here. First, prostaglandins.
Prostaglandins. I know those are targets for painkillers.
Exactly. They're made via the cyclooxygenase, or COX, pathway. They contribute to vasodilation, really amplify the pain signals, and critically, they're responsible for inducing fever.
Right. So prostaglandins, pain promoters and pyrogenics. And that's why NSAIDs, aspirin, ibuprofen work, they block COX.
Precisely. They inhibit prostaglandin synthesis, so less pain, less fever. The other family from arachidonic acid are the leukotrienes, made via the lipoxygenase pathway. These guys are important for increasing vascular permeability too, but a key role, especially for leukotriene B4, is neutrophil chemotaxis.
Chemotaxis, chemical attraction.
Yeah, LTB4 is like a powerful magnet pulling neutrophils, those key immune cells, towards the site of injury.
It's amazing how specific these signals are. Histamine for rapid response, bradykinin for permeability and pain, prostaglandins for pain and fever, leukotrienes calling in the troops.
It's a beautifully coordinated cascade.
But what about dealing directly with, say, bacteria? Is there something specifically for that?
Absolutely. That brings us to the complement system. This is like the bacterial SWAT team. It's a cascade of proteins in your plasma, activated in different ways, but all geared towards dealing with pathogens.
A cascade. So one activates the next, activates the next.
Exactly. Amplifies the response. It has three main jobs. First, it can form something called the membrane attack complex, or MC. This literally punches holes in bacterial cell walls, making them rupture. Boom.
Wow. Direct kill.
Yep. Second, opsonization. Complement fragments, especially one called C3b, coat the bacteria. Think of it like putting little eat me flags or target stickers on them. Makes them much easier for phagocytic cells like neutrophils to grab and engulf.
Opsonization. Makes them tasty for immune cells.
Basically, yeah. And third, inflammation. Other complement fragments like C3a and C5a are powerful chemoattractants they draw in macrophages and neutrophils, amplifying the whole inflammatory response. So complement, cellular cleanup crew.
And makes the attack, opsonization, and calling for backup. Got it. Any other major mediator groups?
One more key group. Cytokines and chemokines. The cellular messengers. These are small proteins, things like interleukin-1, IL-1, and tumor necrosis factor, TNF, mostly made by white blood cells, especially macrophages. They're crucial for communication between immune cells.
Okay.
They have local effects, but also systemic ones, like triggering fever or that general sick feeling, the acute phase response. Chemokines are a special subgroup that specifically direct cell movement chemotaxis again. They provide the navigation signals.
That is quite a network. And now I can really see how these chemicals directly cause those cardinal signs. Redness and heat, that's the vasodilation from histamine, prostaglandins, bradykinins.
Nitric oxide, too, another vasodilator.
Right. And the swelling, that's the increased permeability thanks to histamine, bradykinin, C5a, leukotriene.
Letting that fluid leak out.
The pain, definitely bradykinin, serotonin, prostaglandins.
All stimulating those nerve endings.
And the fever, IL-1, TNF, prostaglandins working on the brain's thermostat.
Exactly. It all connects. It's an immediate, coordinated chemical response to injury.
Okay, so we've got the chemical signals down. Now let's look at the actual events, the action plan. You mentioned two phases, vascular and cellular.
That's right. Let's start with the vascular phase. I like to picture it as the traffic jam and floodgate scenario.
Okay.
So right after the injury, there's actually a super brief vasoconstriction. Just for seconds. Almost negligible.
Blink and you miss it.
Pretty much.
Yeah.
Then comes the main event. Widespread arteriolar vasodilation. The small arteries open up, increasing blood flow dramatically into the local capillary beds. That's your redness and heat. The body's flooding the zone.
Bringing in supplies and maybe warmth helps reactions.
Exactly. More blood means more plasma goodies, more potential cells, and the heat can speed up metabolic processes. Then, crucially, you get that increased vascular permeability, mostly in the venules, the small veins leaving the capillaries.
The floodgates opening you mentioned with histamine and bradykinin.
Yep. Endothelial cells contract, gaps open up, and plasma fluid starts leaking out into the surrounding tissue. This leakage also makes the blood left in the vessels thicker, more viscous, so it slows down. That's vascular stasis, like a traffic jam.
And that slowing down is useful.
Very. It allows the white blood cells, especially neutrophils, which are normally whizzing by in the center of the bloodstream, to move towards the edges of the vessel wall, getting ready for the next step.
Ah, okay. Now, this fluid leakage, the exudate that causes the swelling, let's hit that question again. Why is this actually helpful? It seems like just leaky pipes.
Great question to keep asking. It's far from just leaky pipes. This exudate, this protein-rich fluid, is performing several vital functions. Remember, DAT.
DAT dilutes, antibody delivery, transport.
You got it. First, it dilutes any toxins or harmful agents at the site, spreads them out. Second, it delivers crucial plasma proteins, antibodies to target specific pathogens, complement components for that SWAT team action, and fibrinogen, which clots and helps wall off the area. Third, the fluid flow helps with transport. It facilitates lymphatic drainage, washing antigens and microbes away towards the lymph nodes where a more specific immune response can be mounted.
So the swelling isn't just swelling, it's dilution, delivery, and drainage. That makes so much more sense why it's protective.
Absolutely. And clinically, distinguishing this inflammatory exudate, which is cloudy, protein-rich, from transidate, which is clear, watery, low-protein fluid seen in things like heart failure due to pressure changes, not inflammation, is really important.
Can the type of exudate tell you anything more?
Definitely. If it's purulent, basically pus that's packed with neutrophils, dead cells, often bacteria, screams infection like in an abscess or meningitis. If it's salicurous, like the fluid in a blister, it's mostly plasma fluid, fewer cells. If it's fibrinous, it's rich in fibrinogen and fibrin, often seen on surfaces like the pericardium, causes that characteristic friction rub sound.
Okay, so that covers the vascular chaff. Changes the traffic jam and the purposeful flood. What about the cellular phase, the cells actually doing the work?
Right, this is the neutrophils rescue mission. Neutrophils are the stars of acute inflammation. They're a type of white blood cell, a granulocyte, and they are the first responders, usually dominating the scene in the first 6 to 24 hours.
The shock troops?
Pretty much. They're short-lived but packed with enzymes and chemicals designed to kill bacteria and clean up debris.
So how do they get from inside the blood vessel, through that vessel wall traffic jam, and out into the tissue where the problem is?
That's the elegant four-step dance called extravasation. You can remember the steps with MRAD.
MRAD, okay.
Margination. Because blood flow has slowed down, stasis, the neutrophils drift out of the central flow and line up along the inner surface, the endothelium of the blood vessel. They're getting close to the exit, rolling. They don't just stick immediately. They tumble or roll along the endothelial surface, making brief contact via adhesion molecules called selectins. It's like they're testing the surface, slowing down further.
Hey.
Adhesion, now they stick firmly. Stronger adhesion molecules called integrins on the neutrophil lock onto their partners on the endothelial cells. They're fully stopped, anchored to the wall.
ND.
Diapedesis, also called emigration or migration. The neutrophil actively squeezes itself through the junctions between endothelial cells, crosses the basement membrane, and enters the tissue space. It's like squeezing through a tight gap.
MRAD, margination, rolling, adhesion, diapedesis. It's quite the journey. You had a metaphor.
Yeah, think of a firefighter. Traffic slows near the fire. Margination. They drive slowly along the curb, checking the scene, rolling. They park the truck and grab their gear, ready to go. Adhesion. Then they force their way through a door or window into the burning building. Diapedesis.
That paints a great picture. So now the neutrophil is in the tissue. How does it know exactly where to go?
Chemotaxis. Remember those chemical signals like C5a and leukotriene B4 and bacterial products? They create a chemical gradient, like a scent trail. The neutrophil follows this trail, moving directly towards the highest concentration of these chemotaxins right to the site of injury or infection.
Incredible navigation system. And once it arrives, what's the mission?
The mission is phagocytosis, to engulf and destroy. It involves 3 key steps. First, recognition. The neutrophil has to recognize the target, maybe a bacterium, maybe dead cell debris. This is made much easier if the target is coated with opsonins, those eat-me flags like C3b or antibodies.
Opsonins make them stand out.
Exactly. Second, internalization. The neutrophil extends its membrane around the target and engulfs it, pulling it inside into a little bubble called a phagosome. Third, killing. This phagosome then fuses with lysosomes, sacs full of enzymes and toxic chemicals within the neutrophil to form a phagolysosome.
And that's where the destruction happens.
Yes. Inside the phagolysosome, the neutrophil unleashes its weapons. There's the oxygen-dependent killing, the famous respiratory burst, which generates nasty reactive oxygen species like superoxide and hydrogen peroxide, basically bleach to kill microbes.
Oxidative stress.
Yep. And there's also oxygen-independent killing using enzymes like lysozyme, which attacks bacterial walls, and protease to digest the target.
So phagocytosis is recognition, internalization, and then killing using either oxygen radicals or enzymes.
You've got it.
Now, connecting back again, all these neutrophils rushing in, rolling, sticking, squeezing out, following trails, eating stuff. How does this cellular action actually help us heal? What's the protective benefit?
It's absolutely critical. This cellular infiltration achieves 3 main things. Remember REP? They remove the bad guys, the pathogens. They eliminate foreign material and debris from damaged tissue. And by doing that, they prepare the ground for repair. They clear the battlefield so reconstruction can begin.
REP, remove, eliminate, prepare. Without the neutrophils doing their cleanup job, healing would be stalled.
They're really stalled, or infection would likely take over. They are essential.
Okay, so acute inflammation is designed to be local and protective. But it sounds so powerful. Can it spill over, cause problems elsewhere?
It definitely can. Those potent chemical mediators we talked about, cytokines like IL-1 and TNF, for example, don't always stay local. They can enter the bloodstream and trigger systemic effects like setting off alarms throughout the whole body.
What kind of body-wide alarms are we talking about?
Yeah. One of the most common is fever or pyrexia. This isn't just random heat. Those cytokines, IL-1 and TNF, travel to the brain, specifically the hypothalamus, and tell it to increase prostaglandin E2 production. That PGE2 essentially resets your body's thermostat to a higher set point.
So that's why NSAIDs work on fever too, blocking prostaglandin production.
Exactly. And that brings up that question, is fever good or bad? It's complex. Higher body temperature can inhibit the growth of some bacteria and viruses and maybe enhance immune cell activity.
So potentially helpful.
Potentially, but it also increases metabolic rate, causes discomfort, and in vulnerable people, like young children, high fever can trigger seizures. So it's a balance. We often treat fever for comfort and safety, but acknowledge it might have some defensive role.
Okay. What other systemic effects?
Leukocytosis. That's an increased number of white blood cells circulating in the blood. Often you'll see neutrophilia, more neutrophils, which strongly suggests a bacterial infection. In viral infections, you might see lymphocytosis, more lymphocytes instead.
The body's calling up reinforcements from the bone marrow.
Precisely. Stimulated by other signaling molecules called colony-stimulating factors. You also get the acute phase response. This is where the liver changes what proteins it's making. It ramps up production of things like C-reactive protein, CRP, and fibrinogen markers we actually measure in blood tests to detect inflammation.
Right, CRP and ESR, which relates to fibrinogen.
Yep. And the liver decreases production of others, like albumin. This whole shift contributes to that general feeling of being unwell, malaise, fatigue, lack of appetite you get when you're sick.
And what's the most dangerous systemic effect?
That would be shock. This is a life-threatening situation where the circulatory system fails, leading to dangerously low blood pressure and inadequate blood flow to vital organs.
I mean, inflammation can cause that.
Oh, yes. Septic shock is a major example. If you have a severe infection spreading systemically, the massive release of inflammatory mediators can cause widespread vasodilation and leaky vessels throughout the entire body. Blood pressure plummets. It's an emergency.
That sounds terrifying. Are there stages?
Yes. Shock progresses initially. The body tries to compensate, compensated shock. Then it starts to fail, decompensated shock. And eventually it can become irreversible. Catching it early in the compensated stage is absolutely vital.
Wow. So the body's defense can turn deadly on a systemic level.
Mm.
What about problems locally? Can the inflammation itself cause complications right at the site?
Yes, absolutely. These are the local complications where the cure kind of becomes part of the problem.
Like what?
Well, swelling, for instance. While we know it's needed for DAT, too much swelling in the wrong place can be disastrous. Think about swelling in the airway, like an acute epiglottitis, can block breathing.
A medical emergency.
Totally. Or swelling inside the skull from meningitis, raising intracranial pressure. Or fluid accumulating around the heart in pericarditis, compressing it, cardiac tamponade.
So location is key. What else?
Loss of fluid. In really extensive inflammation, like major burns, the fluid leaking out can be so massive it leads to hypovolemic shock due to low blood volume.
Just from the inflammatory leakage.
Yes. Another issue is digestion of host tissues. Those powerful enzymes neutrophils release to kill bacteria. Sometimes they leak out or are released when the neutrophil dies, and they can damage surrounding healthy tissue. This contributes to abscess formation.
The walled-off plus pockets.
Exactly. The body tries to contain the damage and infection, but that wall also makes it hard for antibiotics and more immune cells to get in. And of course, just the ongoing pain and loss of function can be significant complications in themselves, really impacting a person's life.
So inflammation is a double-edged sword. Essential for defense and healing, but with real potential for harm, both locally and systemically.
It's all about balance and control.
Which leads us to the outcome. What happens after the acute inflammatory battle? What are the possible sequelae, as you call them?
Well, the best case scenario, the ideal outcome, is resolution. This happens when the initial trigger is removed, the mediators break down, the neutrophils die off neatly via apoptosis, the exudate fluid is reabsorbed, and any damaged tissue that can regenerate does so. The tissue basically returns to normal, clean slate.
That's the goal. What if that doesn't happen?
If the trigger persists, especially certain bacteria, you can get separation pus formation. This often leads to an abscess, that localized collection of pus walled off by fibrin and fibrous tissue. Again, tricky to treat because things can't easily get inside that wall.
Needs draining, often.
Often, yes. Drainage and antibiotics. Another possibility, if the trigger just won't go away, maybe a persistent infection or a foreign body or an autoimmune process, is that the acute inflammation transitions into chronic inflammation.
The long-term smoldering fire.
Exactly. This involves different cell types, ongoing tissue injury, and attempts at repair happening simultaneously, often leading to scarring, fibrosis, and permanent changes in the tissue. And sadly, the most severe outcome is death, usually from those overwhelming systemic effects like septic shock or organ failure.
The resolution, suppuration, abscess, chronic inflammation, or death, it really highlights how critical it is to manage inflammation effectively.
Absolutely.
And sometimes the system itself is faulty from the start, right? There are genetic disorders that affect inflammation.
Yes, and they teach us so much about how finely tuned the system needs to be. They show what happens when the system fails.
Give us an example.
Okay, take hereditary angioedema, or HAE. It's a rare genetic condition where people lack a functional C1 esterase inhibitor protein. This protein normally puts the brakes on parts of the complement system, and importantly, on bradykinin production.
Ah, bradykinin, the pain and permeability peptide.
Exactly. So without the inhibitor, they get uncontrolled bursts of bradykinin. This causes recurrent episodes of deep, non-itchy swelling edema in the skin, the gut, and dangerously the larynx. Airway swelling can be fatal.
Wow. So missing one brake pedal causes massive swelling, the anchor.
Think HAE, hugely angry edema. It really underscores the need for control mechanism.
What's another one?
Alpha-1 antitrypsin, A1AT deficiency. This is a more common genetic disorder where you have low levels of A1AT. A1AT is a protease inhibitor. Its main job is to neutralize enzymes, especially elastase, released by neutrophils.
So it protects tissues from the neutrophils' friendly fire.
Precisely. Without enough A1AT, neutrophil elastase goes unchecked and starts destroying delicate tissues, particularly the elastic fibers in the lungs, leading to early-onset emphysema, and it can also damage the liver, causing cirrhosis.
So the check on the neutrophil attack is missing.
Yep. You could think ATTACK alpha-1 trypsin tissue attack check killed.
Okay, one more.
Chronic granulomatous disease, CGD. This is a genetic defect affecting phagocytes, like neutrophils. Specifically, they can't generate that respiratory burst. They can't make the toxic oxygen species needed for potent killing.
So they can eat the bacteria but not kill them effectively.
Exactly. They engulf them, but the killing part is crippled. This leads to recurrent severe bacterial and fungal infections, often starting in infancy. The body tries to wall off these infected cells, forming granulomas, hence the name. So CGD cannot generate destruction.
These disorders really drive home how every piece of the puzzle, the mediators, the cells, the inhibitors, is vital.
Absolutely. Studying them has taught us immense amounts about normal inflammatory pathways.
And clinically, when we suspect acute inflammation, we're often looking at tests, like a full blood count, to check for that leukocytosis.
Especially neutrophilia.
Right. And inflammatory markers like CRP or ESR.
Showing that acute phase response.
And depending on the situation, maybe cultures to find a pathogen, or imaging like X-rays or CT scans to see abscesses or fluid collections.
All tools to piece together the picture based on these underlying processes.
Okay, wow. We've covered a huge amount today. We journeyed through acute inflammation, really understanding its protective side via prize with those cardinal signs. We dissected the chemical signals, the mediators orchestrating everything. We saw the vascular floodgates opening and the neutrophils performing their incredible rescue mission, MRAD and REP.
Yeah, the whole cascade.
And we also saw the dark side, how this local hero can cause systemic problems or local complications, and how fragile the balance is, especially when we look at those genetic disorders like HAE, A1AT deficiency, and CGD.
It's a powerful system.
So, boiling it all down, what's the single most important takeaway for a first-year med student listening to this?
I'd say this. Acute inflammation isn't just a disease process you learn about. It's a fundamental, evolutionarily ancient healing process. The symptoms preach, they aren't just things to get rid of, they are vital clues. Understanding the why and how behind them, the mediators, the cells, the phases that knowledge is foundational. You'll use it constantly to figure out what's wrong with your patients and how to help them. And remember, even when it feels bad, your body is usually trying its best to protect you.
That's a really great perspective.
Yeah.
Your body is trying to help, even when it causes discomfort.
Pretty amazing, really.
It is. Which leads me to a final thought for you, our listener, to ponder. Given this incredible power, this potential for inflammation to cause harm, even as it tries to heal, how does the body usually strike that perfect balance, that fine line between effective defense and destructive overreaction, ensuring things resolve nicely instead of becoming chronic problems? And what really happens at a deeper level when that balance is lost, not just in rare genetic diseases, but maybe in common conditions like arthritis or heart disease? Something to think about.
Definitely food for thought.
Thank you so much for joining us on this deep dive into acute inflammation. Keep asking why, keep that curiosity burning, and keep exploring.